Hello, everyone. Today we have little bit tricky case with membranous nephropathy. 48-year-old male who was referred by the primary care physician for assessment of nephrotic syndrome. He has some weight gain and leg edema, was found to have about 8.6 gram of protein in his urine, and his creatinine has increased from a baseline of 0.8 to 1.6 milligram per deciliter. His anti-PLAR antibody was positive at 93, and his kidney biopsy showed membranous nephropathy, and also the kidney tissue was stained positive for the antiphospholipase A2 receptor antibodies. And the question is, considering a treatment plan, which of the following is most correct? Holding immunosuppressives while initiating ACE inhibitors and monitoring the anti-BLAR antibody is the initial first step for all patients with membranous nephropathy. Is this right? Or cyclophosphamide in combination with glucocorticoids has been shown to be superior to rituximab on the basis of RICYCLO trial, or in the Mentor study, patients who were treated with rituximab and cyclosporin had similar eGFR at 24 months of follow-up? Or the right answer is, in the Mentor study, those patients who were treated with rituximab had higher rates of remission at 24 months? Or is the right answer is, in patients who become sensitized to rituximab, a chimeric type 1 anti-CD20 agent, a fully humanized type 1 anti-CD20, such as ofatumumab, is contraindicated? Which one of these answers are the most correct? And here, the most correct answer is, in Mentor study, those patients who were treated with rituximab had higher rates of remission at 24 months. And in patients with high risk of progression, we need to start the treatment. It's always, we say that we wait for about 3 to 6 months before starting immunosuppressive medication to patients with membranous nephropathy, but this is not true for all patients. Patients at high risk of progression, that they have 2 or more of the following criteria: either decrease in eGFR more than 25% that is not explained by other causes during this 3 to 6 months, or they have significant proteinuria of more than 8 gram per day, or nephrotic range proteinuria with serum albumin going down with nephrotic presentation, or we find that the anti-BLAR antibody is going up, usually above 150. So if we have 2 of those, this patient have a proteinuria of 8.6 gram and also has doubling of his serum creatinine, so he lost more than 25% of his eGFR. So he has 2 indications to start treatment and not to wait. And by the way, patient with progressive decline of eGFR are at a very high risk of progression. So we don't have to wait. We have to initiate immunosuppressive medication. In the RICYCLO trial, it showed that there was no signal of more benefit or less harm using rituximab versus cyclic corticosteroid cyclophosphamide regimen. while in the mentor trial that was done by Mayo Clinic Group, they showed that rituximab was superior to cyclosporin at 24 months, and patients who were treated with rituximab had higher eGFR compared to those who were treated with cyclosporin. And in patients who became sensitized to rituximab, which is a chimeric form, not a fully humanized form of anti-CD20. The fully humanized form of anti-CD20 can be used without a contraindication. So I think this would be a good option to these patients. And here are the references. This is the reference for the mentor trial that was published 2019. And here is the reference for the right cyclo trial that was published in 2021. And of course, you are familiar with the key DIGO guidelines of GN that was published in 2021. Thank you so much and have a good rest of your day.